Thank you for joining us. My name is Jenny Pagel-Guile, and I am the Executive Director of the National Pancreas Foundation. This evening's webinar is Advances in Research, Hope for the Future of Pancreatic Cancer Treatment. We have an esteemed group of panelists this evening, but first I would like to share a little bit about the National Pancreas Foundation. Tonight, we're fulfilling our mission of working with our partners in the field to provide research and education to our community and providing hope for those suffering all forms of pancreatic disease. Also, part of our impact provides support for our medical professional community. We have 185 centers of excellence across the country. We have over 30 programs for patients, physicians, and care providers. And over the years, we have awarded over $5 million in grants. All of you make a difference in our mission, and we appreciate you joining us this evening to continue moving forward. Tonight, we would also like to thank our sponsors for helping us provide this education, Arcus Biosciences of Revolution Medicines. In addition to programs like this one this evening, we have other ways to be involved across the country. We have over 30 chapters in various cities. We also host Pancreas Bowl events and fundraisers. We have March on the Hill. We have advocacy days and a variety of other ways to become involved. If you would like to start a chapter or learn more about what's in your area, you can look on our website, but you can also contact Cheyenne from the MPF staff to find more information. We also host fundraising galas across the country. Part of these is also to recognize our medical partners and professionals through an award ceremony and our patient heroes. We have a schedule of events that are very robust for the fall, kicking off in Pittsburgh and then even into the spring. We hope that you'll be able to join us at one of these events. We are always looking for attendees, volunteers, and donors for these to help us make a successful MPF event season. If you are a runner or know a runner and would like to run for a cure, we have several bibs for races across the country. Our next race is the Peachtree 10K in Atlanta, and we have other races, the Marine Corps Marathon, New York Marathon. These are fundraising bibs, but we would love to have you support and represent the National Pancreas Foundation and these races across the country. Again, reach out to our staff to learn more information and to get registered. Tonight's programming will be posted later on and recorded on our medical professional portal. Our medical professional portal is sponsored by AbbVie. This portal provides webinars for all sorts of healthcare professionals. We provide free CME opportunities for various professionals. We have Pancreas 101 and different webinars, blog posts. We also provide listings of grant opportunities that are available from other institutions. And we also list other CME accreditations and pancreas-related conferences across the country that are provided by our centers of excellence and other partners in the industry. I encourage you to look at our medical professional portal and share those resources. Again, they are free to use, not just to our centers of excellence, but they are open access. So please share those with your community hospital partners or other people in your office that might not be able to attend this webinar. You can view it on the QR code, or if you just go to the Pancreas Foundation website, you'll be able to access it from there as well. Again, for the most up-to-date information, feel free to follow us on social media. We are on Facebook, Twitter, X, LinkedIn, and we also have a monthly newsletter and a variety of other emails that go out. So you can subscribe on our website or follow us on social media for more information of upcoming events or opportunities to be more engaged. With that, I'm going to turn it over to our esteemed panelists this evening. Tonight, our moderator is Dr. Colin Weeks. He is the Christopher D. Horner Endowed Chair in Pancreatic Cancer, the Director, Medical Oncology Research for Pancreatic Cancer at Massachusetts General Hospital Cancer Center, and Associate Professor of Medicine at Harvard Medical School. Dr. Weeks, thank you so much for joining us for Advances in Research, Hope for the Future of Pancreatic Cancer Treatment. And I'll let you share and introduce the rest of our panelists in a bit.
Okay. So thank you everyone for meeting with us today, and we look forward to a really robust presentation. So I'm joined today by Drs. Wungki Park and Mark O'Hara. So I will sort of host tonight's session. I will give an overview of pancreas cancer. This will be followed by updates in clinical trials and new drug development. with a potential focus on RAS inhibition by Dr. Park, and then followed by promising breakthroughs in immunotherapy, precision medicine, early detection by Dr. O'Hara. So with that, we'll go ahead and get started. So here's the problem. So if you look at this graph sort of closely here, what we see is that pancreas cancer is the one cancer in which there's an steadily increasing death rate over the course of time versus the other cancers that are listed here, which are decreasing in death rate over time. And this is the estimates for this for 2025. And what you can see here is that pancreas cancer, so on the left is males, on the right is females. And so on the left, you can see that pancreas cancer is the 9th most common cause of cancer in males and the 7th most common cause of cancer in females. But despite that, it is the 4th and 3rd most common cause of cancer-related deaths in patients in the United States. And this is because pancreas cancer is a very complex disease. And so on the right-hand side, what I'm showing you is an actual histograph of a pancreas cancer tumor. And what I'm showing here is that there's just a small nice of pancreas cancer tumor cells in this entire histograph. And there's a whole large number of additional cell types. And these include what are called cancer-associated fibroblasts, immune cells of various forms, as well as various kinds of pancreas cancer. And all of these different things have different molecular pathways that are responsible for their growth and are areas of potential targeting for therapy. And so, unlike other cancers where if you cut the tumor in half, what you'll see is predominantly cancer cells. Pancreas cancer is a very unique tumor in that it also has the cancer cells, but all these additional cells, as well as the extracellular matrix, which all play a role in the development of the disease. So pancreas cancer itself is a genetic disease, and it's derived from alterations or mutations in these common genes, the most common of which is KRAS, and we'll talk more about this later. But KRAS is the most commonly mutated gene in pancreas cancer. It's one of the very earliest mutations that occur in pancreas cancer. And you can see as you go from these pre-neoplastic lesions, which are called pannins, all the way to an infiltrating tumor, the percentage of cells that have a KRAS mutations are upwards of 90%. And this is now going to be an interesting target for drug development in this disease. In addition, there are a number of hereditary syndromes that also result in pancreas cancer as part of them. And so it is now being recommended that all patients who are diagnosed with pancreas cancer, regardless of their stage, undergo germline mutation analysis, which is meaning the genes that you're born with that may put you at risk of familial pancreas cancer, as well as determination of these genes that you develop as you generate cancer. And these are called somatic mutations. So pancreas cancer is a complex disease I outlined before. It has a number of sort of general symptoms that patients may experience. And depending on the age of the patient, these symptoms can be related to other diseases. And sometimes this results in the delay of the diagnosis of the disease. And this has a lot to do with sort of where the pancreas is located in the body. It's sort of in this pocket where there's not a lot of other organs around it. And so a tumor can grow undetected for extended periods of time and even metastasize before the patient develops symptoms. And symptoms are generally how we detect cancer in most patients. So when we think about sort of the stages of pancreas cancer, as I'm talking to my colleagues about pancreas cancer and the management of these patients, we're talking about really sort of functional stages. And what I mean by that is the cancer relegated just to the pancreas tumor, to the pancreas itself, versus has it spread? And then in terms of thinking about resectability, that's a function of what are the arterial structures that are around the pancreas that are maybe involved. And so as we move from resectable at the bottom of this graph to patients who have metastatic disease, what we'll see is increasing degree of first venous involvement and then arterial involvement. And then next, whether the tumor has metastasized or spread to other parts of the body, If it's spread only to the lungs, that has a different sort of natural course of the disease than if it's spread to other parts of the body, and then to the what degree has it spread. So oligometastatic means that it's spread maybe 2, 3, 4 lesions, versus diffuse metastases can be, up to innumerable lesions within the body. So this is looking at that statement in a different way. And here we're looking at sort of what is the relationship between staging versus survival. And the bottom line in this statement is that, most patients who are diagnosed with pancreas cancer, unfortunately, are diagnosed with metastatic disease. So that's 50+% of patients. Another 20 to 30% of patients are diagnosed with locally, regionally advanced disease. These are patients who have some degree of vascular involvement and can be either borderline or locally advanced unresectable disease. And then there's another 20% of patients who have resectable disease at diagnosis. And those patients, as you would anticipate, do the best. And this is an old slide on the right-hand side, but the shape of the diagram would be the same. It's just that we sort of have now increased benefit. So whereas this says for all stages, the overall 5-year survival is around 4 or 5% in this particular graph, it's now up to 13%. And this has really been a function of developing of these two chemotherapy regimens for the management of metastatic pancreas cancer, which I'll show you in a little bit, have now moved into the management of early diseases. So the first is FOLFIRINOX. So FOLFIRINOX is a combination of 3 chemotherapy regimens, 5-FU, irinotecan, and oxaliplatin. This was compared to gemcitabine, published in 2011, and it showed that patients who received FOLFIRINOX who had metastatic disease untreated had an improvement in overall survival of around 11 months versus gemcitabine at 6.8 months. Similarly, nab-paclitaxel plus gemcitabine was compared to gemcitabine alone and also was able to demonstrate an improved overall survival associated with nab-paclitaxel and gemcitabine versus gemcitabine alone. So this probably, I would say these two findings were probably the most important findings for pancreas cancer patients in the last, say, 20 to 30 years. One is it demonstrated that patients with could withstand multimodality chemotherapy, which had not been sort of the prevailing mantra for these patients going prior to that. And then secondly, because now we are seeing not only improvement in survival, but there's some degree of response associated with these regimens. So around 30% of patients respond to these regimens, meaning their cancer shrinks. Then that sort of began to think about how can we use these in earlier disease settings. So if we think about localized disease and then focus on a sort of resectable disease, these are the studies that are the landmark studies that have been done over time for management of patients with pancreas cancer. So all the way from Conoco 001, which just looked at adjuvant gemcitabine versus observation, adjuvant meaning treatment after surgery, versus the SPAC4 study, which looked at gemcitabine and capecitabine versus gemcitabine, and then the more recent studies, the PERDIS 24, which looked at modified FOLFIRINOX versus gemcitabine in the adjuvant setting, and then the APAC trial, which looked at gemcitabine and nab-paclitaxel versus gemcitabine in the adjuvant setting. And then S1505 was a perioperative study looking at gemcitabine, nab-paclitaxel versus FOLFIRINOX. And so I'm going to focus this conversation on PERDIS 24 and APAC. So in PERDIS 24, the primary endpoint of this study was to look at disease-free survival, which is the time in which you live after having received therapy before you develop metastasis. And so in this study, patients who received modified FOLFIRINOX had a disease-free survival of 21 months versus gemcitabine 12.8 months. If you look at disease-free survival for gemcitabine of 12.8 months, that's what we've seen over time. So that's very consistent with what we've seen in the past and other studies. And interestingly, the overall survival was dramatically improved to 54 months versus 35 months in patients who received modified FOLFIRINOX versus those who received gemcitabine alone. Both the gemcitabine arm was dramatically improved over what we'd seen in the past, as well as the modified FOLFIRINOX arm. So this sort of implicates that these patients also received effective therapy for their metastatic disease as well. If you look at the APAC trial, so the APAC trial once again looked at patients receiving 6 months of a nab-paclitaxel plus gemcitabine versus gemcitabine in the adjuvant setting. The primary endpoint of the study was overall survival as determined by central review. That means that all the radiology imagings was sent to central radiologists, and they reviewed it. And in that setting, what they showed was that patients there was not an overall survival benefit associated with that. So then they went back and looked at if we use the historical way of doing this, which is investigator review of radiology results. And in that setting, they were able to demonstrate that there's an improvement in overall survival in patients who received nab-paclitaxel and gemcitabine versus gemcitabine. So this study has been used for the utilization of adjuvant gemcitabine and nab-paclitaxel in this patient population, although it is less commonly used than, say, modified FOLFIRINOX for most patients. So if we look at the adjuvant studies over time, what we can see is a steadily improvement in 5-year survival associated with these therapies to now with modified FOLFIRINOX, we see a 5-year survival around 43%. And this has been a strong contributor to the improvement in 5-year survival for all patients with pancreas cancer that we've observed over the last few years. So this is a study that we did at MGH. It's a small study, but it's just to demonstrate a point. So this is a study of neoadjuvant therapy. So what this means is receiving therapy prior to going to surgery. This is in patients with borderline resectable disease, meaning they had some degree of venous vascular involvement. And these patients received modified FOLFIRINOX for 4 months, followed by chemotherapy and radiation, followed by surgery. And what it showed is that if you just take patients who go on to this study, R0 resection rate means that the tumor has been removed and the margins in which the tumor has been removed are negative. And that has been shown to improve survival in patients, or been correlated with survival in patients with pancreas cancer. And so you can see that all patients in an intent to treat analysis who went to surgery, all patients treated in the study with an intent to treat analysis, 65% of those patients had an R0 resection. And the median overall survival for those patients is 37 months. And then the median progression-free survival is 14.7 months. If you then look at the patients who are resected, and you ask how many of those patients had an R0 resection, it's 97% of patients who are resected. And now you see an improvement in median progression-free survival of 48 months versus, and then the overall survival is not reached. So this information would support potentially the use of neoadjuvant therapy for patients with this disease. And once again, this is borderline resectable disease, so a little bit more advanced than what I showed you in the previous slide. Now, this has been assessed in sort of larger studies, and this study looked at the addition of radiation therapy plus FOLFIRINOX versus FOLFIRINOX. And the point of this particular slide is that it demonstrated that there was some, in patients who received radiation therapy, there was an inferior outcome than those patients who received FOLFIRINOX alone. This is a large study, and I think when you look at this study more closely in detail, what you'll see is that there's potentially differences in the radiation that was given to these patients. And so this study outlines a significant problem that we have with these types of studies when they get to larger cohorts of institutions. We then run into some problems due to technical differences in how individuals apply radiation therapy or even surgery in this patient population. So it's been a little bit challenging to do these larger studies looking at neoadjuvant therapy for those reasons. So if we move on to precision medicine, And what I'd like to talk a little bit about is the impact of tumor heterogeneity in chemotherapy response. And so, as I said before, the most important, I think, outcomes that we've seen in the last few years is the application of multimodality chemotherapy to patients with pancreas cancer. And so I showed you earlier that when we use FOLFIRINOX versus gemcitabine, FOLFIRINOX seemed to be better. Nab-paclitaxel versus gemcitabine, nab-paclitaxel seemed to be better. There really have been no head-to-head studies asking the question of which of those two multimodality therapies are better. This study looked at a regimen called nab-paclitaxel. So nab-paclitaxel is 5-FU, liposomal irinotecan, and oxaliplatin versus FOLFIRINOX, which is 5-FU, traditional irinotecan, and oxaliplatin. So really sort of FOLFIRINOX-like regimen. And what it showed is that patients who received nab-paclitaxel had a better outcome than patients who received nab-paclitaxel and gemcitabine. And although we're not supposed to do cross study comparing, if you look at the FOLFIRINOX PRODIGE study, the median overall survival in that study was 11.1 months, very similar to the 11.1 months that we see here in nab-paclitaxel. So this study would suggest that the 3-drug chemotherapy regimen of nab-paclitaxel or FOLFIRINOX is a better treatment regimen than nab-paclitaxel and gemcitabine in our patients. Now, interestingly, this is a study that was done in Japan called the GENERATE study. And in this study, they compared patients with nab-paclitaxel gemcitabine versus FOLFIRINOX versus this drug called S1, irinotecan oxaliplatin. So it's a derivative of 5-FU that is used in Asia. And what they demonstrated is that patients who received nab-paclitaxel and gemcitabine in this particular patient population had a significant improvement in overall survival, now 17 months, so much greater than we've ever seen before, versus 14 months for modified FOLFIRINOX. So now this is a Japanese study. The studies that I talked about with the FOLFIRINOX was a French study, and then nab-paclitaxel was a sort of a US-based Western Europe study. So is this really a case of sort of ancestral genomics or pharmacogenomics that are playing a role in these differences in patients? It does begin to make us think more about sort of which patient population should be receiving what chemotherapy regimen to begin with. Historically, we've chosen the chemotherapy regimens based upon our perceived assessment of the patient's tolerability of these regimens. So patients who are younger, more fit, they tend to get FOLFIRINOX as their first-line chemotherapy. Patients who may be deemed to be a little bit more frail or older may receive nab-paclitaxel and gemcitabine or another 2-drug regimen such as something like FOLFOX. And so now really thinking about how does genetics or genomics play a role in how we think about therapy. So a potential answer to this question is demonstrated by the COMPASS trial. So in this particular graph, what we're showing here is that there are different molecular subtypes of patients with pancreas cancer. Some pancreas cancer cells are determined to be what we call classical or epithelial, and then other pancreas cancer cells are thought to be what we call basal or quasi-mesenchymal, and this is based upon transcriptional signatures. And as it turns out, our pancreas tumors in a patient are a mixture of these different cell types. And so the COMPASS trial showed that in patients who were predominantly epithelial tumors, which are shown, or classical, which is shown here in the purple, those patients had a predominant response to FOLFIRINOX-based therapy. And interesting, those patients who are basal, shown here in yellow, those patients tend to have upfront resistance to FOLFIRINOX therapy. And this response results in an improvement in progression-free survival for those patients who have a classical phenotype, which is measured here by GATA6 RNA site dehybridization. More recently, the PASS-001 study looked at randomized patients who received either gemcitabine or FOLFIRINOX, and then asked this question in the back end, and it showed the same thing, in which patients who had a classical phenotype, those patients respond to chemotherapy preferentially, whether it be FOLFIRINOX or gemcitabine, nab-paclitaxel. But the true difference in outcome was actually seen in those patients who received FOLFIRINOX. Those patients who received FOLFIRINOX did have an improved progression-free survival versus the patients who received nab-paclitaxel as their agent. So as we move into precision medicine and looking at the molecular landscape, as I outlined before, the most common mutation that we see in patients with metastatic pancreas cancer is the KRAS mutation, followed by cyclin dependent kinase N2A, p53, and SMAD4. These are some areas where molecular therapy has a role in pancreas cancer. So for patients with what are called MSI high, which is a very small fraction of patients, those patients do tend to respond to pembrolizumab, which is an immune checkpoint inhibitor. Patients with NTRK mutations, patients with BRAF V600E mutations, RET mutations, and then the BRCA mutant population of patients. And so as we think about sort of what's been the most important development for pancreas cancer in the past 30 years, one could say, well, is it improved surgical techniques? Is it radiation therapy or different forms of radiation therapy, combination chemotherapy, or molecular classification of tumors? So I would argue that the answer to this question is C for the past. For the future, which I do believe is bright for patients with pancreas cancer, this is going to be where molecular classification of tumors come into play. And these are sort of molecular therapies focused on KRAS and other molecular abnormalities. Now thinking about immunotherapy, antibody-drug conjugates, radioligand therapies. I think also thinking about experimental imaging and how that can help us to determine response to therapy. And then an important thing is to understand in the setting of minimal residual disease. So these are patients who have undergone surgery. They don't have any evidence of cancer in their body, but we know that some proportion of those patients still have cancer. And so how do we detect those patients and how do we treat those patients? So I think those are the important questions going forward. And so with that, I'd like to thank you for listening to me and thank you for your time. I'm now going to move on to Dr. Park. I'm going to stop. He's a medical oncologist and physician scientist who specializes in the caring of patients with pancreas and biliary system cancers. He is a member of the David Rubenstein Center for Pancreas Cancer Research at Memorial Sloan Kettering Cancer Center, where he focuses on resistance mechanisms to immunotherapy, the tumor microenvironment, DNA damage repair, and KRAS. Dr. Park.
Thank you, Dr. Weeks, for kind introduction. So good evening, everyone. It's my honor to represent Memorial Sloan Kettering at this National Pancreas Foundation webinar. I'm a GI medical oncologist at Memorial Sloan Kettering. I focus on developing smarter and biology-driven clinical trials in pancreas cancer. So translating progress to me, it means not just designing trials, but restoring time, strength, and real hope for our patients. So I usually start with my collage, and my work really begins with and ends with patients, and this collage really represents those I've learned from and run for and work alongside, and to bring a better treatment to our patients and into the real world. So our science is powered by our patients and the people like this here. Some of these patients shown here are actually my own patients and who have been on the POLAR trial, been on this study for more than 3 years, and they are living fuller life and longer lives through clinical trials. So pancreas cancer has had bad names and has been called intractable, immune desert, KRAS mutant, and biologically silent. But this disease is really beginning to talk to us, and I think we're learning how to listen. So 93% of the patients have a KRAS mutation, and it's a really early clonal event. And so KRAS is the backbone of the pancreas cancer, really. And we've learned that it evolves and it intensifies as it grows and it progresses and changes its phenotype. So starting from the penin 1 to 2 precancerous lesion to the cancer, and from the classical to you just heard from Dr. Week's presentation to the basal-like and to the mesenchymal, it intensifies. You can see the third row from the bottom, the mRNA expression increases, and it gets darker color towards the right as the grade of the cancer actually changes and evolves. So this is only G12D, but we're learning a lot more about carcinogenesis and how this is so important and pillar of a pancreas cancer. So directly targeting KRAS G12C was not available until just recently, and about 2 years ago, it's only about 1%, but it really opened the door for pancreas cancer. And though it is really rare in pancreas cancer, G12C drugs like adagrasib and sotorasib. Here is about adagrasib shown in the picture. In the KRAS finally turned into undruggable to druggable, and we're really learning from lung cancer folks that building smarter trials for pancreas cancer is also much needed. So it really sparked the field, and you can see on the left side is a monotherapy response rate of 42%. As a pill, it's just phenomenal, and it's never heard of in pancreas cancer. And on the right side, it's a colorectal cancer, so different disease, but my colleague Yeager has shown that adding EGFR monoclonal antibody together with a KRAS inhibitor, you can add about 20% increment, so the response gets a little bit deeper. So this is just an example that combination will be always needed, and to improve our outcome, smarter designs are always needed. And so direct targeting for KRAS G12C is possible because of the chemical structure, and the switch II pocket inhibitors are like adagrasib and sotorasib. These are forming a covalent bond to the cysteine in the KRAS G12C. C stands for cysteine, but other major alleles that are most common in pancreas cancer, like G12D, like aspartate, and V, like valine, they don't have those pockets. So, hard to really anchor a drug, and it really requires some innovative, creative thinking. And we have amazing scientists who've developed multiple different strategies. So KRAS stays in two different states: off state, that is GDP bound, and on state, that is GTP bound, and then they exchange and circulate. As the currency changes and exchanges one to the other, the balance shifts off. In the past, those drugs like sotorasib, adagrasib, they target the off state KRAS, and it worked. But in the new era, on the right side, you can see things like a tri-complex mutant selective allele or pan-RAS multi-on state inhibitors like RMC6236 or daraxonrasib, so-called, has been really revolutionizing the field. You can also see new strategies now. Instead of finding the pocket, they're actually degrading the tumor associated KRAS protein. So these newer strategies are very exciting and innovative, and it's really opening the doors. First off, daraxonrasib has, formerly called the RMC6236, is a new drug that targets multiple types of KRAS mutations, not just the one. So it can be very versatile, and for patients with the different tumor profiles. So at the moment, this is currently being tested. And in this study on the left side, in this phase 1, we participated. 36% of the patients, saw their tumors shrink, and 91% of them actually stabilized. So showing a really promising result, even in the advanced cancer of the pancreas. You can see on the right upper side, 93% of the patients had more than 50% of their cell-free DNA RAS variant allele frequency reduction. So that's a really quick and deep response and biochemical or genetic response in the early stage, even before you can actually scan them and see the imaging radiographic findings. So it's how powerful it is, and it's now moved into a phase 3 trial called the Resolute, and it's currently ongoing in a randomized fashion. And many of you should seek this trial locally. we're also learning, that, how secondary resistant mechanism develops from follow-up cell-free DNAs and biopsies. And, the field is moving really quickly. This is ASP3082. It's a G12D mutant allele first-in-class drug that is targeted protein degrader, aimed to specifically target the G12D protein. And G12D is the most common one, that is about 40% found in pancreas cancer. So once the patients reached at the right dose, you can see on the left side, we saw clear signs that the drug was degrading the G12D protein inside and is shrinking the tumors. Responses are early but encouraging, and with some patients staying on treatment and responding for over a year. So I see that this is very promising and ongoing development is happening. While targeted drugs, go after known mutations like KRAS, and, many precision approaches are happening, and it's very important we provide treatments to targeted group of patients with less toxicity and more efficacy. Cancer vaccine is sort of a targeted therapy in a way too, and I won't dwell on it too much because, Dr. O'Hara will discuss a lot more on the immunotherapy and vaccine. But this is also very exciting. In the last year or two, cancer vaccines, we used to call immune desert in pancreas cancer, but it is shown to work and, show a really promising result. So it really shows the proof of concept that if you select well and, give the right drug, the immune system will actually take good care of pancreas cancer, even if it is immune desert. And it usually works more and better in a very minimal residual disease setting. So, they train the immune system to really recognize the tumor as a threat and fight back. And, so now we're exploring how to personalize these vaccines and using each patient's tumor blueprint, just like the fingerprint. So this is a personalized mRNA vaccine from our group that helped some patients generate the long-lasting CD8 T cell that recognizes and fight back their own tumor. Patients who responded showed a longer recurrence-free survival in the red curve on the left upper side. And you can see I actually circled here on the right side. The punchline of this study is that you generate a lot of a good CD8 T cell response, and some of them are so fit and good that they live long, really long, outlive an average of 7 years and plus. And you can see they have a convergence of evolution starting from this peak after the priming of the vaccine. The peak of this turns into from green into orange and purple. Look at them. Initially, the peak raises the proportion of the green proportion, which is proliferating T cell. And then the purple and orange, it changes and evolves, converges into effector T cell that is the worker of the T cell that destroys the cancer, and also the tissue resident TRM T cells, meaning it's a memory that is printed inside the tumor so that they will do the job. So it's amazing how advance of the cancer vaccine is doing something that was not imaginable in the past. On the other side of vaccine development, the previous one is kind of a bespoke and made per person, so it's not ready-made and it's not off the shelf. This is the off-the-shelf KRAS peptide vaccine. The study here shown is only 2 peptide, but at the moment, 7 peptide vaccine is ongoing. And the bottom line here is that no matter which dose it was, if you give vaccine, the vaccine was successfully priming and increasing the fold of immune response, and CD8 T cell increase on the right upper side. And it's still too much premature to tell, but you can see the graph of the Kaplan-Meier curve starts separating from the beginning in red and blue. So yes, we're hopeful that the study will be effective for our patients after surgery. So other targets of currently developed in antibodies and biologics, so we call and antibody drug conjugates. I'll just briefly brush upon them. it's really important to understand the Claudin 18.2 as a target is a classical marker. And most of the oncologists and scientists will know in pancreas world that, classical versus basal versus mesenchymal is not one type only, but they are kind of a spectrum, and most of them kind of coexist within the tumor. If you look at the left side of the tumor, of a resected tumor, and compared to the right side, it may be actually different. And so Claudin is a known target, and it's a classical marker. It gets released, and the epitope can be used when cell-to-cell tight junction gets more loosened. And currently there's a lot of trial options being evaluated. The most advanced one at the moment is a GLEAM trial called zolbetuximab is the drug, is a monoclonal antibody IgG1 against the Claudin 18.2. Currently approved for gastric cancer. We use exactly the same drug in an international randomized phase 2 trial in 369 patients. Completed accrual, and we're waiting for the final readout and evaluation. So stay tuned. And same target is being evaluated for bispecifics, meaning like a BiTE, you're engaging immune cells or any other target that you want to block or you want to engage, or CAR T or any other different strategies are currently being evaluated at the moment. We also evaluated a different surface target called tissue factor. It's not only the surface target, but it's known to be quite highly expressed in pancreas cancer, associated with the thrombosis and a worse prognosis. Using this antibody drug conjugate, carrying the payload of the chemotherapy into the tissue factor high tumors, it's very selected small group of patients, but we saw some early signal that it may be helpful. So there's some update that we plan on presenting at ESMO, so please stay tuned. So there's a lot more of early stage and late stage different trials, but it's a busy slide and I'm so sorry. Late stage, at least we also have seen that immune modulating agents using chemotherapy backbone like the CD73 and CD40, antibodies show meaningful clinical benefit in clinical trials, and a wave of early stage bispecifics and antibody conjugates will coming next. Last but not the least, HRD. So BRCA mutated and its cousins have been evaluated, and this is a trial that we designed at MSK. We looked at patients with the BRCA mutation as well as cousin mutations, and none of those mutations, but only by platinum sensitivity. We switched them over to olaparib and pembrolizumab maintenance therapy. We designed this as a result of olaparib single agent being FDA approved, and thought that combining this will probably prime their cancer better and immune system will work better for them. Currently, this is in manuscript writing mode, and we have a lot of samples from a lot of dedicated patients, and we're analyzing and we'll learn a lot from them. The biggest punchline here is that 3-year overall survival rate is still maturing, but was 58%. In Polo, it was 34%, and cross-trial comparison is not possible, and this is only phase 2, but I think it is very promising, and we have some clue about why this is happening, so please stay tuned. So I hope I was able to really convince you that pancreatic cancer is not cold anymore, and pancreatic cancer isn't, this is a turning point, and the key now is finding rational biology-driven combinations that makes a real difference for our patients. And this requires really a lot of work from our colleagues and all of you, and a lot of voices to get more funding, because people like me and Dr. Weeks and Dr. O'Hara really need funding to get this work so that we can pay back to you. So thank you so much for staying tuned.
Thank you, Dr. Park. Now we'll move on to Dr. O'Hara. Dr. Mark O'Hara is an associate professor of medicine at University of Pennsylvania, where he is an early drug development guru. Focuses his work really on sort of looking at different aspects of immunotherapy. And so Dr. O'Hara will update us on sort of what's the novel things happening in immunotherapy in pancreas cancer.
Thank you, Dr. Weeks, for the kind introduction, and thank you for the invitation to talk today. You know, in the 15 minutes that I have to talk right now, we're going to be talking about some of the promising breakthroughs in immunotherapy, precision medicine, and early detection. And it is actually, luckily, actually kind of difficult to capture everything that's sort of promising breakthroughs that are up and coming, kind of taking things from the lab and going into the clinic. And so from my perspective, I focus on a lot of aspects that are showing some clinical promise. And kind of hopefully will be something in the near future, something that would give some possible indications in pancreatic cancer, some more therapies for pancreatic cancer patients as we're all trying to work forward to move that needle forward. My disclosures. So first, I want to open up about immunotherapy in pancreatic cancer. And immunotherapy is one of these things that's sort of a key word that we oftentimes hear when we meet patients with pancreatic cancer or any cancer for that matter. Immunotherapy has really kind of revolutionized how we manage patients of other cancers. But unfortunately, when it comes to the immunotherapy as we know it right now in the clinic, in pancreatic cancer, it's unfortunately not all that effective. If we look at kind of taking the single agent therapies that we have, so the PD-1 inhibitors, pembrolizumab or Keytruda, nivolumab or Opdivo, or durvalumab, tremelimumab, and ipilimumab, if we take these medicines, these therapies overall, we see actually there's very little by way of response, 0% response rates across the board for single and double agent immunotherapies. Moreover, if we take a page from other cancers and we try and combine immunotherapies with chemotherapy, we see that the response rates actually match what we'd expect mostly with just chemotherapy alone. So the immunotherapy does not add too much by way of chemotherapy to the effects of chemotherapy. And part of the reason why we think that pancreatic cancer is different from other cancers is that it actually relies on this tumor microenvironment. It's a very complex microenvironment that has an interplay between cancer cells and support cells that actually kind of put up a barrier to immunotherapy. It used to put up a barrier to a lot of our systemic therapies, chemotherapies, and still does to this day. And I think actually it's key to actually getting immunotherapy to work is to actually be able to crack down on this complex tumor microenvironment. We see actually a lot of this microenvironment driven in the middle of this picture here by mutant forms of KRAS that drives low tumor mutational burden, low MHC1 expression, which is necessary for initiating an immune reaction, low antigenic strength and immune privilege, and then resulting in kind of low infiltration of T cells. T cells are the important cells to kind of initiate the immune reaction. Give me 1 second, sorry, I just lost my slides. Can you still see the slides?
Yes.
There we go. Sorry about that. And then there's also an infiltration of myeloid cells that kind of put up a complex interplay between all immune cells here to actually kind of lead to an immune desert or a cold tumor microenvironment, as well as an infiltration of cancer-associated fibroblasts and dense desmoplasia that also creates a both physical barrier as well as a complex interplay between immune cells and and cancer cells and the stroma that actually makes immunotherapy largely ineffective. And so a lot of our work and all the reasons why immunotherapy doesn't work can be summarized by actually looking at these complex interplay of all of these different types of cells. Where we're seeing immunotherapy kind of move the needle a little bit forward was actually mentioned by Dr. Park on the previous slide is actually in the vaccine therapy. And in these vaccine therapies, part of the reason why we actually see some efficacy is because it's being studied in a setting in which patients actually have minimal residual disease, so after surgery and adjuvant chemotherapy. And so the disease that's existing at that point hasn't actually created this tumor microenvironment that's putting up the barrier. And that's part of the reason why I think we're seeing some of the efficacy that we're seeing in vaccine therapy in that setting, but not so much in the metastatic setting where the tumor itself has grown to a point where we can see it on scans and therefore has created this tumor microenvironment that's putting up that coldness against the immune system. Just going a little bit into the two vaccine studies that Dr. Park had mentioned in the previous presentation. The first one is the personalized RNA neoantigen vaccine from Sloan Kettering initially. This vaccine itself is a personalized vaccine, so it's actually made by the tumor tissue itself. And so patients undergo a primary resection of their tumor. They isolate both the normal DNA and the tumor RNA, and then they go through an algorithm to actually predict and select neoantigens that are found in this tumor. And then they custom manufacture this vaccine. This process, obviously takes quite some time, but in this time, the patient's recovering from the surgery itself. When they're dosed, they receive a dose of a PD-1 inhibitor, atezolizumab, followed by 8 doses of the vaccine weekly. And then after completion of these 8 doses, they undergo their 12 cycles of adjuvant FOLFIRINOX and then get a booster vaccine after completion of adjuvant chemotherapy. On this study itself, 34 patients were screened and consented, 32 enrolled, and then 19 received atezolizumab, 16 received the vaccine, and 15 received the FOLFIRINOX. Looking at some of the data, and I realize this is a busy slide, there's a lot of information that's in this manuscript, and I'll direct you to it if you're interested in learning more about that. There's both one from 2023 and an updated one in 2025. But basically what they saw is that there were sort of responders, those that actually had T-cell responses to the neoantigens, the non-responders, those that didn't actually create strong T-cell responses to the vaccine itself. And Dr. Park had mentioned earlier that those actually that did respond tended to actually have a higher median recurrence-free survival. So those that are the good responders, which were about 8 of them, had a high level of recurrence-free survival. Those that actually did not have much of a response had a recurrence-free survival that was sort of similar to what we'd expect with just adjuvant chemotherapy itself. And then looking at both the recurrence-free survival and then similar with the overall survival in this publication. What they did find is that 2 patients that actually were considered responders did actually recur in the future, and actually if you looked at the actual neoantigen response, the T-cell response that was associated with those 2 patients, it was less than the other patients in that cohort. And so indicating, similar to what Dr. Park had mentioned, that a strong immune response to this vaccine is what drives this better overall outcome, that the immune system can be primed by this vaccine and can work to try and decrease or increase the curability of pancreatic cancer itself. And Dr. Park mentioned the persistence of these T cells over years, which is going to be important for preventing that pancreatic cancer recurrence. This vaccine study has now moved into a randomized study in which patients receive the vaccine plus atezolizumab and FOLFIRINOX versus FOLFIRINOX alone. So it's compared to the standard control arm in patients with resected pancreatic cancer, and that is continuing to enroll. And looking forward to the results of that in the near future to see if we truly are having responses. And I'm hoping that we see results that are similar to what we're seeing in this early clinical trial, because it really is a fascinating story itself. Switching gears to that off-the-shelf vaccine that Dr. Park had mentioned, this is the mutant KRAS vaccine. This is using 2 peptides, 2 forms of mutant KRAS, KRAS G12D and KRAS G12R. That's tagged to an albumin-binding lipid, and then they use a vaccine adjuvant. This vaccine is then injected into the arms and then taken up by the lymph nodes, and then creating T-cell responses, the hope is, to mutant forms of KRAS that will then attack any kind of minimal residual disease that may be around, again, in the after-surgery setting. In this trial here that was published back in 2024, what they did is they enrolled patients that actually had what we consider high-risk features, so either an elevated CA19-9 after surgery and adjuvant chemotherapy, or a positive circulating tumor DNA indicating a potential minimal residual disease. And what they found is that there's a number of patients that had a good response in these residual markers. Now, this is looking at both pancreatic cancer and colon cancer, but the vast majority of patients on this trial were pancreatic cancer. And what they found is that those patients that tend to have a higher T-cell responses, looking at the second to last line on the left side here, tended to have a deeper response in their either CA19-9 or circulating tumor DNA. And that's shown both at the left as well as at the right-hand side of this slide here. What we found also is that those that actually had increasing clearance overall had a higher T cell response, like we said, reduction itself, and then this actually translated to an improved median recurrence-free survival, as shown down in the lower right-hand corner here. So putting this all together, both of these vaccine studies are showing that it is potential to create an immune reaction against either mutant KRAS or the neoantigens in the first one, and that actually could potentially lead to an improved overall survival. And this, just similar to the last one, has been translated into a randomized controlled trial, which patients had already received surgery and adjuvant chemotherapy, and then they were randomized to receive either standard of care, which would be monitoring, or the vaccine. And again, in this vaccine is using 7 peptides rather than the 2 peptides in this earlier study. So looking at more KRAS mutant variants. Again, this study is actually completed enrollment. We're waiting for a readout and sort of seeing if this might be something that could potentially move forward as well. I don't want to pretend that it's only in this adjuvant, post-adjuvant setting that we can actually see some improvement with immunotherapy. And again, Dr. Park did actually mention these in passing as well. We can actually get patients with metastatic disease to respond to immunotherapy. And certainly in the number of clinical trials that I've run with immunotherapy, I have seen some benefit from immunotherapy in certain patients. It's just finding those right patients and who actually might respond. We have had some promising results of some phase 1, phase 2 studies that have now moved into phase 2, phase 3 studies that will hope that are enrolling or about to enroll here. The first one is using a CD73 inhibitor. So this is CD73 is a drug that actually creates adenosine. And so if you inhibit it, you decrease the adenosine in the tumor microenvironment. Adenosine is something that's immune, that basically knocks down the immune system, makes it inactive. And so if you knock down the amount of adenosine, the immune system can be more active and therefore potentially lead to more immune activity. The study of quemliclustat with chemotherapy was read out. The phase 1b showed a response rate of 41%, progression-free survival of 8.8 months, and median overall survival of 19.4 months. And this is a metastatic disease first line, gemcitabine, nab-paclitaxel, and the CD73 inhibitor. And so now they're looking at that in a phase 3 study that's currently enrolling, PRISM-1. It's looking at chemotherapy plus the CD73 inhibitor versus placebo and chemotherapy. The second study is a smaller phase 2/3 study that's being done, but it's a drug that's actually been studied over the years, OT-101. This is a anti-TGF-beta antisense, so it actually knocks down TGF-beta, which is an important immune regulator within the microenvironment of pancreatic cancer. What they found earlier on was actually that if you gave this drug in patients sort of this is in the phase 1 study, gave this drug and followed that by standard of care chemotherapy. This is in the second line and beyond. There was a median overall survival of 9.4 months, which is pretty impressive in the second line and beyond setting. If you gave the drug but no follow-up chemotherapy, the median overall survival was only about 2.8 months. And so something about this that actually can prime the activity for the chemotherapy to potentially work even better in this disease. And so they have a phase 2/3 study that's looking at this agent plus FOLFIRINOX in patients with advanced and unresectable metastatic pancreatic cancer, open at 2 sites across the country. And the last one is looking at a CD40 agonist. There's been some work done on CD40 agonists, working at Penn, and then also some of the studies that I've run myself have looked at CD40 agonists. This is a way to kind of lead to increased antigen priming and activation of T cells. This is mitazalimab, which is a CD40 agonist from Alligator, that in their phase 1b/2 study looking at FOLFIRINOX in combination with CD40 agonist, they saw a response rate of about 40%, progression-free survival of 7.4 months, and a median overall survival of 14.3 months. And they're getting ready to start to enroll of a clinical trial, a phase 3 trial in the first line setting of FOLFIRINOX with or without mitazalimab, the CD40 agonist in previously untreated metastatic disease. So there's a potential that we could see some activity in the first line setting, but I think what's going to be key to all of this is actually understanding why we're not necessarily seeing a response, kind of learning from these clinical trials. If we actually are seeing patients that are responding, why are they responding? And if we're seeing patients that are not responding, why are they not responding? So what can we do in future trials to actually make sure that we can actually make patients look like those patients that might respond, so that we can actually potentially move the needle forward of immunotherapy in pancreatic cancer? We're going to shift gears a little bit and look at precision medicine. And I think all of us have actually mentioned precision medicine at this point. And some of this has actually been duplicative, like looking at this, for example, Dr. Weeks had mentioned some of the targeted therapies that we have that are available for use in pancreatic cancer. A lot of these are sort of pan-RAS approvals. But looking at what I would consider some of the targeted therapies, the PARP inhibitors are for BRCA1, BRCA2, and PALB2 mutations. That's looking at, I know it's a wide range, 3 to 15%. We saw 48% on Dr. Weeks. Really kind of looks, it depends on which paper you're looking at in terms of the frequencies of these potentially inherited mutations. And then looking at the rarer mutations themselves, dabrafenib and trametinib for V600E, again, in 2 to 3% of patients with pancreas cancer, trastuzumab deruxtecan with HER2 positive disease, erdafitinib for FGFR alterations, pembro for high tumor mutational burdens or microsatellite unstable patients, again, very unlikely, about 1% of patients, selpercatinib for RET fusions, again, less than 1%, and then looking at various NTRK inhibitors for the infrequent NTRK fusions, and then recently the approval of the newest drug for pancreatic cancer, zenocutuzumab, for NRG fusions. We'll go through some of the data on that one here. So NRG1 is an epidermal growth factor. It binds to HER3 through an EGFR or EGF-like binding domain that triggers the HER3 and HER2 to bind together, resulting in downstream proliferation. We see that NRG1 fusions occur, well, infrequently, about 1% of, or less than 1% of the time. If patients are KRAS wild type, it does occur more frequently. And so certainly something to consider if you're actually getting sequencing on patients, that if they're KRAS wild type, they have a higher likelihood of not just NRG1 fusions, but all of the other fusions that we mentioned before, the NTRK fusions, the RET fusions, that could potentially lead to some potential targeted therapies. Zenocutuzumab is a bispecific antibody that's directed against HER2 and HER3, so it has some potential activity for these NRG1 fusions. What we see in the clinical trial is that if we look at this is looking at various cancers with NRG1 fusions, but if you look at just the pancreatic cancer patients, there's a 42% objective response rate and a 7.4-month duration of response that is shown there on the left, and then also in the swimmer's lane plot at the right. Overall, this seems to be pretty decently tolerated as well. I'm not going to go through all the potential side effects there on the left, but overall, in the scheme of things, pretty well tolerated in therapies. And so this has been granted accelerated approval by the FDA for use. And so certainly important to get next generation sequencing with a fusion panel on your patients, or if you are a patient, to actually request that you get a sequencing with a fusion panel to see if this may be a potential option for you sometime in the future as well. Lastly, and sort of brief, I know I'm getting near the end of my time here, but we're going to look at some breakthroughs in early detection. The biggest one is a big clinical trial. I'm sorry for the blurriness of this slide. It's the CAPS-5 study. This is a multi-center study looking at pancreatic cancer screening in patients that are high risk for developing pancreatic cancer, those that actually have an inherited mutation such as BRCA1, 2, PALB2, ATM, other inherited mutations in CDKN2A or STK11, and then also includes patients that have a family history of at least one first-degree relative and one second-degree relative with pancreatic cancer, are potentially eligible to undergo screening for pancreatic cancer. And the surveillance protocol uses a combination of endoscopic ultrasounds as well as MRIs and blood work, CA19-9. They also undergo blood collections as well as aspiration of pancreatic fluids to actually use that analysis for further analysis to see if there's any circulating markers or pancreatic specific markers that they can detect that might actually help them design maybe a less invasive way of actually monitoring patients down the road. This is the outcomes that were published back in 2022, but they saw that at that point had a little over 1,700 patients, and 42% of them had germline mutations. The rest had the family history. Overall, in this large patient population, they had 26 patients that were diagnosed with pancreatic cancer. That means that one individual was diagnosed with pancreatic cancer for every 194 patients screened, which is obviously a small percentage, but still an important percentage for those patients that were diagnosed with pancreatic cancer in this high-risk population. In those that actually had pancreatic cancer, about 40% of them had a germline variant. And then There was 19 of those 26 patients were diagnosed with surveillance, which means 7 patients were actually diagnosed without actually undergoing surveillance. They were diagnosed sort of after surveillance was complete or had not been undergoing the surveillance that was recommended. And so what they saw here is that those that actually underwent surveillance on the left here, so A, that the pancreatic cancers that were detected during surveillance were actually mostly in the lower stage, so kind of looking at stage 1 and 2, and so potentially in that curable setting, or stage 3, that only about 5% of them were stage 4 at diagnosis, whereas those that actually were detected outside of surveillance, the vast majority were stage 4, unfortunately, and potentially and likely incurable. This is looking at patients that also had surgeries for some concerning reasons. Looking at the green line, that's high-grade dysplasia. Blue line is those that were diagnosed with those local pancreatic cancers, and red lines were those that were diagnosed outside of surveillance. So those are the green and blue were those in the surveillance group, and those red were not surveillance. So unfortunately, those with outside of surveillance had worse outcomes, but those with the undergoing the surveillance protocol had overall better outcomes in general. So for those that with high risk, I think this is something that's certainly worth looking into overall. And it's a study that's currently enrolling at sites across the US. And so if you are a patient or a family member or a family member of a patient that would be potentially eligible for this, it's something to certainly look into to increase potential screening modalities for pancreatic cancer. Beyond that, though, there is work being done, and this is not an exhaustive list whatsoever, of looking at some blood tests. And I know there's a question that was in the chat earlier today to look at ways that we can actually earlier diagnose pancreatic cancer in sort of a less invasive way. There's one study that's sort of that's been getting a little bit more press recently. It's looking at circulating exosomes and CA19-9 together that actually was able to detect 97% of stage 1 and 2 pancreatic cancer. So these patients were actually, or these studies were done in patients that actually blood was collected from known pancreatic cancer or healthy controls, and they compared it. And this blood test would have predicted the pancreatic cancer that was there compared to healthy controls. This was done in 4 different countries. There was some variability in terms of the readouts of each one of the countries, sort of speaking to some of the ethnic differences or differences within pancreatic cancers itself. But certainly something that's moving forward right now and needs to be studied more prospectively to be able to get to a point where we might be able to use it in a broader population. The second one is Pacman. So this is a protease cleavable peptide probe that was able to detect about 80% of pancreatic cancers compared to control. And that when you combine that with CA19-9, the sensitivity increased to 85% and 96% specificity for stage 1 pancreatic cancer. So again, another early study, but looking at some of these circulating markers as ways to potentially detect pancreatic cancer that's less invasive than the endoscopic ultrasounds and the MRIs, and perhaps maybe broader to not just those with high risk, maybe a bigger screening. Certainly more work needs to be done in this, but it's something that's of keen interest because, as Dr. Weeks had mentioned, in terms of diagnosing the pancreatic cancer, unfortunately, the vast majority of people are diagnosed late, mostly related because of the lack of symptoms related to pancreatic cancer. And so certainly something that's an interesting way of looking forward and hopefully preventing the discovery of pancreatic cancer late overall. So in conclusion, I think everything that I'm touching on is still an area of investigation in pancreatic cancer, but we're seeing some hints of some increasing promise. And so we think that the vaccine in the postoperative setting is showing some promise, as well as some novel immunotherapies and immunotherapy. My hope is that we can push immunotherapies moving forward and see if we can actually see some of the drastic changes in outcomes in pancreatic cancer, similar to what we've seen in other cancers as immunotherapies are more and more effective. Targeted therapies are limited because of the small population of patients that actually have those potential targets. But I think, as Dr. Park had mentioned, looking at KRAS inhibitors, I think that's going to be something that's going to revolutionize how we manage patients with pancreatic cancer. And I think understanding both how KRAS inhibitors work, what are the resistance mechanisms, and how it actually might be able to interplay with other therapies, including immunotherapies, to see if we can actually get them to work even better in pancreatic cancer. I think that's actually going to be a key to unlocking some of the hardness that we've had in terms of managing pancreatic cancer overall. And then looking at early detection, again, we're very early on looking at these modalities, but I think something of keen interest across the board, both for patients and family members alike. And so thank you so much for your time. I know we have a question and answer session coming up.
All right, thank you, Dr. O'Hara and Dr. Park. Can you guys both join me? And we'll try to address some of the questions that have been sort of put out in the chat in both the question and answer sessions. I think the first question that's really sort of, I think will sort of be the foundation for how we move forward is, to each of you, what's the one sort of thing that you think is really important for the future of pancreas cancer therapy, and an area that you want to sort of focus on going forward? Dr. Park, go ahead.
I think we all have a common theme that we are most excited about, which is precision approach and profiling patients better, and not one size fits all approach, and trying to maximize on the efficacy and minimize on the toxicity, and KRAS and immunotherapy also, like everything else. I think you need to tailor the treatment so that you maximize on the effort. So
I would echo that. As an immunotherapist at heart, and trying to get actually pancreatic cancer to be one of those cancers that respond to immunotherapy has been a challenge in my career, but also a challenge that I think is certainly enlightening. As we run clinical trials and unfortunately see that that across the board, maybe it's quote unquote negative trial because the vast majority of patients don't necessarily benefit. There are subsets of patients that can benefit. And if we can actually continue to advance the science such that we actually take science from the lab, bring it to the clinic, see what's happening in patients, and then bring it back to the lab so we can understand it and see if we can actually move it forward again back into the clinic with a better understanding as to that precision approach, who actually might be the ones that might be able to benefit. What are the resistance mechanisms? How can we do a different combination? How can we do a different timing of therapies? I think that's going to be key to actually moving things forward. And I speak from the immunotherapy perspective, but I can also say that's true with KRAS inhibitors as well, or other targeted therapies.
Yeah, and I would say from my perspective, I think sort of there's a question about ethnicity and outcomes with pancreas cancer. And we talked a little bit about the GENERATE study and the differences that we saw in that population of patients versus what we see in sort of, let's say, the North American population. And so one of the things I'm really interested in is thinking about how can we utilize science and precision medicine to understand ethnic and ancestral differences, and maybe a possibility to sort of address cancer is to utilize these strategies that we have in sort of patient-specific mechanisms, but also I'm thinking about this in sort of a more global point of view, and how we can utilize these things to sort of address very small differences in biology that may or may not be related to ethnicity or social environments, and harness those into thinking about therapies for patients. So that's sort of my interest going forward, which sort of combines all of the things that we're all talking about. There's a question here about young individuals being diagnosed with pancreas cancer more commonly, more frequently. Can you guys sort of address that in terms of, let's say, the familial cancer syndromes versus sort of sporadic pancreas cancer in younger patients?
I mean, I think we're seeing younger patients both actually in both of those avenues that are occurring because of some inherited condition, BRCA1, BRCA2, PALB2, something of that nature that we've mentioned. But I also think we're seeing an increasing incidence of pancreatic cancer kind of across the board at younger populations, similar to other cancers like colorectal cancers. I think we're seeing this shift over. I wish that I could sit here and say that we had our answer as to why. I think that's definitely an area that we're digging into. There's got to be something environmental or in our diet or something like that. Not one thing in particular, but something within that that's actually causing a normal pancreatic cell to kind of jump into a cancer mode. And so I do, we understand it's happening, and I think we have to definitely dig into that because I think if we don't, I think we'll be in a similar boat where we're going to see more and more younger patients in our clinics with pancreatic cancer at this point.
So there's a couple questions on IPMNs. So these are intrapapillary mucinous neoplasms, and they're sort of how they differ, say, from pancreas adenocarcinoma that we talk about most commonly and that we talked about in today's conversation, and also the other question is sort of are IPMNs being used in pancreas cancer research? So do you guys want to address that in any way, or I can address it a little bit as well?
You wanna take a stab at it?
Okay. So IPMNs versus say pancreas ductal adenocarcinoma. So pancreas cancer, pancreas ductal adenocarcinoma is really a disease that's based upon early developments of KRAS mutations in most patients. So it's really a KRAS driven disease. Whereas pancreas ductal, or excuse me, IPMNs are actually driven by another gene called GNAS. And so these are they use very different developmental pathways to result in the same process in the end. So there are in many institutions, there are sort of these tumor nodule clinics where they're looking at, say, like in essence, they're like screening programs for pancreas cancer. And in many institutions, that's where the pancreas cancer screening programs are housed. And so in these patients, they would undergo periodic endoscopies, periodic imaging to sort of look at the changes in the IPMNs over time. But these are mostly benign tumors, and it's not uncommon for us to see IPMNs and sort of other parts of the pancreas tumor away from or the pancreas away from where the actual pancreas adenocarcinoma is. And so, yes, IPMNs are being used in pancreas cancer research. They're providing valuable information on the genetics of the disease, and also thinking about, therapies for those. And at some point in time, it may be that we're developing therapies for IPMN related cancers, maybe differently than, say, our traditional pancreas ductal adenocarcinomas. Can either of you talk to the role of AI and machine learning in pancreas cancer research at this time?
Yeah, I can probably comment. So I think in this stage, this world, this rapid pace of development of AI is really impossible to avoid it. And a lot of things we do, including even just data analysis that we do day in, day in and day out, it actually uses a lot of AI technique. But I think the biggest gain we'll get, I think, is probably the early detection program. You'll have a lot of attributes and high throughput of those attributes being analyzed and funneling into the computer system, I think will be very, very high yield. So yeah, we do have different interests in that regard at the moment. And yeah, just speaking of the same, either IPMN or other people of early onset disease is definitely rising. And not everyone will develop from the IPMN, but stratifying and understanding who will have a higher risk and when that will occur. So for example, like highly sensitive methylome detecting and the fragmentome detecting different DNA detection program and different things should be better stratified for those people, I think, and will probably save more. So I do anticipate AI will play a lot more role down the road. So we should all work together. I mean, more data, I'm sure we'll learn more.
And I think it also, you mentioned, I think the PURIS study as well as spatial analyses of tumors, right? And so I think AI will be important in sort of developing those computer algorithms to understand how to implement those tools into clinical care. There's a question here about the utilization of, I cannot say this word for the life of me, daraxonrasib in the adjuvant setting. So I know a little bit about that, but Dr. Park probably knows more. And then, so the question is, will RMC 6236 be used in the resectable disease, so as adjuvant
Oh
therapy?
yeah. I don't think. Yeah, there is a plan, I think. Yeah, I don't think I can share all the details, but there is a plan, I think. Yeah. Yeah, we mentioned it in the JCO review recently, kind of hinting that's coming. I mean, when it's so effective, I think people are already thinking ahead of time at the next stage and next stage already. So it's not a secret. I think it's pretty, yeah.
Yeah. And then the same thing applies for the Elicio vaccine, right? So I think we're waiting for the readout of that study to sort of ask the question of its utilization in minimal residual disease. But one could also think about how it could be utilized in the adjuvant setting as well. I think it's the other cool thing about that vaccine and potentially the vaccine that's being developed at Memorial Sloan Kettering, the personalized vaccine, to Dr. O'Hare's point, is thinking about how you can combine, say, those vaccines with these RAS targeted agents in that they're minimal toxicity associated with those drugs. So it's very uncommon for drugs to have really minimal to no toxicity, and particularly immune targeted agents. So it'll be interesting to see how or if those can be combined with RAS inhibitors as well. We've addressed most of the questions here. Unless I missed some. Oh, so one question is to all of us, which is, I have about a few hundred patients who have been sequenced. What potential research area to dig into, and what do you think is the appropriate questions to ask in that setting? So, Dr. O'Hara, can you talk about that in the context of immune therapy?
I mean, a lot of that would be dependent upon, I guess, what type of next generation sequencing results we have itself. I don't think we necessarily, I mean, one of the handicaps we have in pancreatic cancer and immunotherapy is unfortunately we haven't gotten it to work in a larger population. One of the, I guess sort of speaking to that personalized approach, one trial that we had that it was a CD40 agonist that was not effective. We did find that there was actually something that could predict responses, but it was actually something that we don't get out of next generation sequencing. We get out of a flow cytometry looking at cellular cell levels, immune cell levels, and so using something novel to select those patients is kind of where we're transitioning that study to. For next generation sequencing, as it waits to, aside from looking at sort of tumor mutational burden itself, which is inevitably pretty low for most patients with pancreas cancer, there's really not much we can glean in terms of responses to immunotherapy from next generation sequencing. I think how a lot of these mutations might actually play a role as we're kind of looking at other targeted therapies. So for example, as we're doing KRAS inhibitors, or KRAS inhibitor is going to be effective if there's sort of other co-mutations that might be playing a role in terms of increasing resistance. Obviously not something we can do with patients that have been sequenced before on chemotherapy, and not necessarily one of these therapies.
Dr. Park, how would you address that?
Sorry, address the next generation sequencing question?
Yeah.
Oh yeah. Yeah, I think I agree with Dr. O'Hara that the level of the next generation sequencing is different, and for example, like the simplest thing still, like the neoantigen calling is not really as great for such a small domain that sequenced just for the hotspots for 500 genes plus, so it's going to be challenging and stratifying it. And also just based on our experience up to now, immunotherapy will probably work only in a very subset group who still have a good neoantigen with a less barrier of myeloid and stroma. So that's like a very highly selected group that is, I would say, less than maybe at most 10%, not even 10 probably. So like we need to figure out how to excite them better, and I think that's the question that we're all working on together.
So speaking of exciting them, so Dr. O'Hara, what's your thoughts on RFA or histotrypsy and sort of functioning in that role to sort of excite the immune system?
I mean, certainly, I don't think we have necessarily any specifically data. Histotrypsy being relatively new, I don't think we have any data in pancreatic cancer as it is used to kind of potentially modulate immunotherapy. RFA used in a small subset of patients, I think, with pancreas cancer, but kind of, the way I look at this, similar to radiation, I guess is how I'm drawing a parallel here, is using these modalities to kill off some cancer cells, to release some antigens so that then the immune system can be activated. And then can you actually bring in immunotherapy at that point to make it potentially more effective because you have a more specific response? to the cancer itself. And I think it's definitely an interesting strategy. I think we've got some publication. One also that we ran a trial here of radiation and dual checkpoint inhibition, and it's in the process of being written up at this point. But there is a potential that these modalities can actually sort of ignite the immune system. It doesn't work for everyone, and in part it actually kind of relates to the degree of attack that you get on the cancer cell. It also might, histotripsy and RFA, generally we're doing more in the liver itself. We actually had more responses if we radiate, say, the lung, because it's a little bit more immunogenic, and we had a little bit higher response. So what you actually kill off with the local approach will be important. But I think it's definitely an area of extreme interest and has the potential to really kind of modulate immunotherapy.
Dr. Harrell, can we just finish this conversation a little bit? You just mentioned sort of the immune microenvironment in the lung versus the liver. Can you talk a little bit about that and the implications for therapy for pancreas cancer?
Yeah, I think a lot of what we're seeing is, especially, and it's across cancers, but also specifically with pancreatic cancer, most of the metastases are spread to the liver, and the liver is generally thought to be a kind of an immune desert. And so that could be part of the role as to why we're actually seeing lack of efficacy of these immunotherapies in pancreas cancer. Those that have lung predominant disease overall do better. We know you mentioned that in your talk. And then also tend to actually have some efficacy. And we can kind of draw a parallel to some of the CTLA-4 PD-1 responses in colorectal cancer and lung predominant disease. We know that the immune system there is just different. There's a lot more immune cells there. There's a lot of lymph nodes that are activated. And so potentially you could actually just, those with actually lung predominant disease might be a subset of patients that could potentially respond better to immunotherapy, just because their immune system around the cancer, that the microenvironment is more set up to actually be able to respond. And so I think the site of metastasis is definitely important. And I think there's a lot of research being done in the lab that are actually looking at that as to why liver metastases don't respond, and what can we do to actually make them look, perhaps the microenvironment to look a little bit more like what we'd see in the lung itself.
So thank you. I'd like to thank both you, Dr. Park, Dr. O'Hara, for your time tonight. I think you guys did an excellent job, and I don't know if there's any last parting words from our host, but once again, thank you.
Great. Thank you for everyone. Thank you so much for the speakers. This has been a really great and engaging talk. The webinar is recorded and it will be sent to all the registrants and on our YouTube video channel by tomorrow. Thank you and have a good night, everyone.
Thank you, everyone. Thank you.